All right, thank you everybody. Good afternoon, this is Lisette Fowler and I would like to welcome you to the Public Health PBRN Virtual Monthly Research in Progress presentation for the month of May. Dr. Mace and Dr. Hoover are unavailable. They're not going to be able to join us today. Actually, I think Anna is on the phone and she might drop in depending on her availability. But no worries, Dr. Memorial, CB to many of you, and I will be your host for today. As Dr. Mays likes to say, we do have an action-packed agenda today, beginning with our Research in Progress presentation by the New York PBRN. Our presenters, Brittany Johnson and Victoria Rogan, will be discussing their work on HIV-STD partner services. This was work that was initially developed from the Research Implementation Award that the New York PBRN received back in 2011, I believe, another RWJF award. And they've now incorporated their newest project, the Delivery and Cost Studies Award, into this work. Before we begin, I do want to give a shout out to Brittany. Brittany has been invited to present her work on conducting economic assessment of the integrated HIV-STD field services program operations and service delivery at the Center for Disease Control and Prevention Forum on Public Health Services and Systems Research and Practice. This forum is a platform for CDC staff to engage and learn how public health services and systems research impacts and informs population health. The audience for this forum is not only CDC scientists, but also policy and program staff. So this is a great opportunity to highlight both ongoing work and future opportunities for collaboration with among our center and the work that you all are doing in the CDC. Brittany will be joined by a number of high-level officials. So again, kudos to her for this opportunity. So without further ado, I'm going to turn it over to Brittany and Victoria.
Shucks, Lizette, thank you for the introduction. And I really thank the Coordinating Center for the invite. I think it'll be a really great opportunity to kind of showcase all the PBRN research that's going on and, convince the CDC that it's a really good thing that they should totally invest a lot more money into. But I'll get started. As far as moving the slides, Lizette?
Brittany, you can either ask me to do it, or in the bottom gray bar on the left, there's an up and down arrow, and the down arrow will just move it to the next page.
Bottom left. I don't think we have that.
Try it now.
Oh, there.
Try it now. Sorry.
There it is. That works out. Okay, great. All right, so let's get started. So I'm here, this is Brittany Johnson. I'm here with Tori Rogan, who is our research assistant who's been working with us on this DAX project, kind of the outgrowth of our Research Implementation Award on optimizing HIV-STD partner services strategies. The quick overview, for those of you who are unaware of New York as the STD state, I'll give a little project background about what led to our DAX study. And since this is research in progress, I really want to focus on some of the project components that we've been spending a lot of time on lately. Notably the site visits that we've been doing to collect cost research, a time study that we've developed, and a cost collection and review and presentation of some of those preliminary findings. I'll hand it over to Tori for that to talk about some of the challenges that we've encountered with that process, go through the lessons that we've learned, and give an update on our research timeline and the next steps for this project. So the quick background, the primer that I usually try to do on partner services, it's one of those key public health programs that the CDC really recommends for anybody who's diagnosed with HIV or a sexually transmitted infection, specifically syphilis, gonorrhea, or chlamydia. In 2008, the CDC integrated guidelines for this, which were historically separate for HIV and STDs, into this kind of integrated recommendations, including partner services for all new cases of HIV and syphilis, and then as health department resources allow for gonorrhea and chlamydia infection, with the goal of making sure that people who are diagnosed are getting treated, their partners are getting notified, tested, treated, and if testing positive, getting linked to care. So the background, in 2010, the PBRN got a Research Implementation Award to look at the integration of field services. So following those CDC integrated recommendations, New York State was trying to be proactive, and they merged their field services program so they could better deliver those integrated services at the front line and the field level. And this included two programs, the counseling and testing program for HIV and the partner services programs for HIV and STD. And so when we were looking at the effectiveness, efficiency, and acceptability of this integration process in 6 regional office settings across the state that encompassed about 40 disease investigators, as well as program staff, additional associated program staff. I've covered a lot of this stuff in previous presentations at Keeneland, so I won't go into it in too much detail. We did a mixed methods approach. We did a lot of primary data collection, assessing staff competencies and cross-training, job satisfaction, satisfaction with the integration process. We did some qualitative research and focus groups to get into the details of how the integration process went at the field level and surveyed medical providers. But for this part, I want to focus on the outcomes assessment and the economic evaluation, which were the two main components that really led to the development of our DAX study. So when we looked at the outcomes related to this integrated process and what workers were spending their time on, that first pie chart to the left shows that the majority of time under this integrated model was spent on case investigations, on new positives for cases for HIV and STD partner services. Workers weren't really spending a whole lot of their days sitting in clinics doing counseling and testing in clinic and community and correctional sites. I mean, the majority of their day was really these case investigations. But when we looked into what types of cases were being worked, you can see the pie chart on the right shows that gonorrhea and chlamydia made up really the overwhelming majority of case investigations in terms of just numbers of cases that they were going through, while HIV and syphilis really made up a minority of their workload. While when it comes to assigning cases that are diagnosed, we were working 100% of those cases that were diagnosed, but they just weren't that, there weren't that many of them, especially relative to chlamydia and gonorrhea. And so when we looked at the case outcomes in terms of what are workers accomplishing on these cases by investigating them, we saw that the majority of cases, particularly for chlamydia, had been previously treated, which would mean that the worker would see this case report come up as a new positive, prioritize it if it was, say, a young female or a pregnant woman, follow up with the doctor, verify that they were treated, follow up with partners, and verify that they were treated. In many cases, most of these people were already previously treated, so we weren't really delivering an active intervention so much as verifying that the intervention on the medical side happened. And that kind of led to the question of, is this really the best use of our staff time, particularly these really skilled disease investigators? How should we measure and allocate these resources? And when we looked in the literature to see if this was, just something unique to New York State, we found that this is kind of a national issue. Surveys that they've done on partner notification and partner services show that like the overwhelming majority of interviews were for those types of gonorrhea and chlamydia infection, despite really reaching a small percentage of people diagnosed. So if our goal is curbing infection or preventing disease transmission, this may not be the most effective tactic to use. When we look at it in terms of medical costs, an untreated case of chlamydia or gonorrhea, the cost of that over the lifetime still dwarfs something like HIV. So we'd have to be preventing or averting a lot of infections of chlamydia and gonorrhea to equal, preventing one case of HIV. And particularly in this day and age when we know that there are other tools in the kind of prevention toolkit, like expedited partner therapy that can be delivered by a medical provider to verify, to get these partners treated, is using disease investigators for partner services for these types of cases really the best use of our time. So that led to kind of the genesis of our delivery and cost study. We really wanted to dig in to better understand the cost and effort associated with the case investigation process for HIV, for STDs, and to kind of use that data to figure out what is a cost-effective use of time. Is what we're doing really having a strong impact? Are there ways that we could change or reallocate resources to more optimally allocate staff time and effort? And this coincided really well with a new strategy that New York State is trying to do, utilizing partner services staff to relink HIV positive patients who are out of care back into care. So it's something kind of we've coined as the high impact HIV partner services. The CDC is really pushing this as a strategy to use surveillance data and kind of improve the cascade of care for HIV. And so we kind of had that natural experiment happening in county health departments where we had some staff utilizing this high impact and following up with existing positives, while other partner services staff were doing the partner services that we had studied under the integration model. So we've kind of expanded our research sites to these 4 local health departments in New York State that are using this, involved in this pilot project, as well as the integrated state offices that are continuing on with this HIV STD partner services work. The distilled aims of our DAX project obviously are to build off the research that we already have to look at county and state delivered partner services programs. We have a pretty good handle at what goes on at the state level, but we really don't know how partner services works at the county level. So we wanted to learn more about that. We wanted to look at how this high impact strategy might impact staff effort and program costs, if these cases are more labor or time intensive, what it might mean if we were to roll this out as a statewide initiative. And we wanted to use the cost data that we had collected at the state level and look at some cost data from the county level and kind of combine that with more information on the partner services process to model the cost and cost effectiveness of these programs and figure out when reallocating resources will really improve efficiency and maximize the public health impact we can have. So I'll jump right into the work that we've been doing since we were awarded the grant. We started out with local health department site visits. We've been doing a couple things simultaneously. I'll take them one at a time, but these were all kind of happening together. We wanted to do site visits because, again, you've been to one health department, you've been to one health department. We really didn't know what to expect at the county level for these programs. So we wanted to go meet with program staff and supervisors to better understand the workflow for their regular partner services cases and understand how the linkage to care, high impact HIV partner services cases worked at the county level. We had worked on developing a time study instrument, and we wanted to get staff feedback on whether that instrument was useful, whether it would fit well into their workflow, and whether we'd be able to collect data from it. And more importantly, we really wanted to secure buy-in from the workers and supervisors at the county level. PBRN research is, while it's relatively well known here at the state, there were a lot of new staff who are unfamiliar with the role of practice-based research and what these research projects meant or might mean to them. And so getting that buy-in was part of ensuring that we're going to get good data back and that they feel it's a collaborative process. So with our DAX team, we developed a semi-structured interview guide to get at some of those questions about workflow and effort and time allocation at the county level. We did key informant interviews with 11 partner services staff at the counties and all 4 supervisors at the county level. We mapped the workflow process related to partner services, so that was the number and types of staff that are involved in a case investigation. We tried to get at, understand all of the data systems and shadow systems that were being utilized. Of course, we know that there are some systems that the state says they use to monitor these programs, and then at the county level there are other systems that really make up the majority of their day-to-day work or that they use to really guide their operations. And also to look at structural and geographic differences that might influence what goes into a case investigation or how much time a case investigation might take. And so we did these site visits, Tori and I, between March and May of 2014. We just wrapped those up, and we're digesting some of that information right now. The results, of course, as expected, was 4 counties and 4 different models of partner services. Everybody, even though it was a program with the same goals, was implemented in many different ways. At the county level, which was something we didn't see at the state level really, 40% of staff had multiple responsibilities beyond their stated job description as a disease investigator or a partner services program supervisor. Some staff doubled up as supervisor and investigator. Other staff were working part-time with a TB program. Some supervisors were managing entire STD clinics and public health nurses or entire communicable disease programs, of which partner services is really just a small part. So that really helped us understand that there are many hats at the county level that you don't necessarily see from the perspective that we started with. We saw a large variation in the record-keeping systems. There are 2 state-run systems that are used for surveillance data and case monitoring, but we found 7 additional systems in these 4 health departments. Each county had at least 1 additional paper or electronic system. So you're talking about 3 different systems for data entry at a minimum at the county level, which obviously is going to play into the effort that goes into tracking and documenting these cases. 2 of the 4 counties also were co-located in STD clinics. So for disease investigation staff there, they had overlapping clinic responsibilities, whether it was being on call or getting pulled away from their regular case flow work to handle walk-ins or open clinic days. We did all that, and then at the same time, we've kind of been putting together this time study. We're designing and developing a time study instrument to track partner services work. The motivation was, of course, to understand the case process. How does time and effort differ between chlamydia, gonorrhea, syphilis, regular HIV, high-impact HIV? Some of the qualitative focus group research from our last project indicated that not all cases are created equal. Some are pretty neat and tidy and you can close them up in a few hours, while other cases could be open for months or longer. So we really wanted to quantify the effort spent on these cases with more precision, and also figure out what types of work go into those case investigations, whether it's paperwork, travel, or provider contact. In an ideal world, we describe partner services as sitting down with a patient and giving them counseling and risk reduction services and helping them engage in care, but there's a lot of other stuff that we know goes into this process that really isn't captured by any of the systems we have right now. So we're doing this time study. We want to do it in the regional offices that we've been working with and those 4 county health departments. So about 55 disease investigators in total that we want to do this time study with. We want to design an instrument. Before we said, here, let's just do a time study, we thought about what we really wanted to get out of it and how we would make sure that the outcomes we have are the best they can be. So we wanted to design an instrument that is acceptable to staff. Everybody hears time study and they get a little nervous, especially in an era of budget cuts and layoffs. Workers get nervous about being monitored at such a level, down to the minute. So we had to make sure that the instrument that we designed would be something that staff would want to use and would be able to use honestly. We wanted an instrument that was generalizable across study sites. Again, we have 9 different sites. We know that the way that they conduct partner services is a little different everywhere. We wanted to make sure we had a tool that made sense and was capturing the same types of work at each site. We also wanted an instrument that was useful to academics and practitioners. I think one of the perils of practice-based research when researchers develop tools is that there's all sorts of great questions we want to answer, but then those results might not be relevant for practitioners. So we wanted to make sure that there was something in it for everybody and that the results could be used both for improving practice and for our larger academic questions. And we also wanted to make sure it was confidential, both, again, in being acceptable to staff, that this was, the results weren't going to be shared or used in a negative way. And especially when we're working with HIV data, we have the added issue of confidentiality and legality with HIV data, making sure that there's no identifying information or reference to this so workers can take these tracking instruments into the field. So we reviewed the time study literature. We had a couple meetings with our DAX team and our practice partners to try and navigate what we desired versus what would be really plausible to do in a real-world practice setting. The mock instrument that we developed, we went with that instrument to the local health departments to get some feedback from them on categories that we might be missing or descriptions that might not capture all the work that's being done. So as a response to all of that, we ended up with an instrument that is aiming at tracking the life of a case from beginning to end. So a new infection that gets assigned from the worker that it gets assigned to the day that they close it, as opposed to tracking a worker's progress from 9 to 5 for a 2 or 3 week period. And this is a big part of making sure workers didn't feel it wasn't about them as individuals so much as about the case process. In generalizable, we vetted all these category descriptions with staff to make sure that we were capturing everything. We structured the categories to answer specific research and practice questions, which I'll show in just a minute. And confidential, we designed this without any identifying information and have it set up so that these time study instruments are going directly to the research team instead of through program supervisors or mid-level managers, which makes workers feel a little bit more comfortable about being honest with the data they're sending in. So this is what our time study instrument looks like. I had some fancy animations here, but thankfully I numbered them, and I can just kind of walk through those a little bit. The tracking numbers, that box 1 up in the top corner, will allow us to track the worker and the site location, and the CDIS or state numbers are kind of unique record numbers assigned to cases that are investigated so that we can link it to case outcomes in the surveillance system. Box number 2, we broke down the process into the index case and partner notification sections. From the outcomes research on the last project, we saw that a lot of cases that may be assigned for investigation don't ever actually get interviewed, or may get interviewed but don't elicit any partners. So lumping it all under partner notification really erases a lot of the work that gets done in the lead up to those cases that hasn't been tracked. So we're really trying to track that at a better level. We've added categories like external case preparation, that yellow box. So in some sites, there are support staff or surveillance clerks who help prepare the case before it is assigned for investigation by the worker. In many situations they don't have that support staff, but we also wanted to be able to capture that if multiple people were working on a case. Box 4, or the yellow boxes by 4, we stratified documentation into computer and paper. We know that these partner services cases involve a lot of paper, 8-page interview forms and record forms and copying and putting things into multiple locations. So we really wanted to break down what happens on paper and what might be entered into data entry systems. We're adding miles traveled. This is kind of more of an academic addition. We realize that every county and site tracks travel a little bit differently, and it's really hard to compare them. So we wanted to get an estimate of how much travel is really associated with case investigations. We've structured it, box 6, the date the case is completed by the worker, as opposed to the date that it might be submitted or closed by the supervisor, because there are often time lags between when a worker is really done with a case and when it might be sent into our system for closure. So we wanted to make sure that we were really looking at the work that the worker was doing and the time to process for an actual investigation, as opposed to when a worker might, or a supervisor might sign off on it. And of course, again, sticking with the confidentiality, box 7 there, we have all these forms getting sent directly to our DAX team, as opposed to collected by a supervisor and sent in. And this is on the back of every one of those time study logs, the criteria. And again, this is the kind of stuff that we vetted with staff to make sure that we captured all of those categories, and everybody would know how to enter in and how to categorize this information. So for the implementation of the time study, we settled on a systematic random case sampling method, basically going by every nth case assigned in a region or county, based on estimates from 2012 and 2013 case assignment data that we got from program management systems and surveillance data. So every 5th case, every other HIV, every single syphilis case. To try and get, we're aiming for just over 600 cases to track across about 50 workers, which thankfully is not too much work per individual worker, but will give us a really good sample size to look at the variation and the average time to process for these different types of cases. We're getting ready to get this time study on the ground starting in June, and it's going to run for 3 months through August 2014. Obviously, with any time study, there are limitations. The concern of self-report bias, which we tried to address by making sure that workers were sending that directly to us. We know in some counties there are staffing shortages or workforce changes, such as new disease investigators who might not be able to do as many of these case time study logs as we'd like. There's always the risk in public health of outbreaks that may be diverting staff resources. And that case assignments are dependent on disease incidence. If there are no cases of a certain type, like HIV or syphilis, being diagnosed, we obviously can't track them, the investigations that ensue. So it may take us a little bit longer to reach some of the case numbers we need for those infections, depending again on incidence. And there is a risk of imperfect implementation of the random sampling of those nth cases, but we're trying to build in cross-checks, like recording the cases that are being assigned for tracking, so that we know the records that come in match the records that were randomized for assignment. So that's my portion of it. And hopefully we'll get some good data coming in on that through this summer. I'd like to turn it over to Tori, though, who can talk a little bit about collecting program costs.
Thanks so much, Brittany. Hi, everybody. I'm Victoria Rogan. I'm working with the University of Albany in the School of Public Health, and I'm going to cover the collection of the program costs for this section of the project. So that's how you change that. All right, so we began our cost collection by reviewing the contracts given to the 4 pilot counties to provide partner services. And we attempted to extract the number of FTEs, the salary and fringe, their travel, their supplies, their space and building costs. And we took a micro-costing approach, and we went from the program perspective so that we were able to include both the state and the county costs. And we really did this for 2 reasons. The first is that micro-costing is it's more accurate, and I think that we have the resources to do this more rigorous methodology. The second reason was because we wanted to make this as generalizable as possible, so that if another county wanted to do this in a state that has a more decentralized structure, the evidence from this pilot would still be applicable in that state. So as Brittany mentioned, HIV and STD field services have been integrated in New York. However, our funding sources have not been. So New York provides funding through two separate contracts, an HIV and an STD contract. And both of these fund disease investigation. However, they also fund some other activities, such as prevention and education activities, which really aren't part of what we're studying. So that's something that we kind of have to work on pulling apart from each other. There's also a third contract which funds this specific the high intervention HIV pilot project, and that's only in those 4 counties who are participating in that pilot. So how did we go about collecting and analyzing our cost data? We started by performing a line item review of the contracts and extracting the relevant information. Then we stratified it out by county and contract, and then put each of the expenditures into categories. We specifically used vouchered costs, which are basically the costs for which the county can provide receipts, as opposed to what they budgeted. And then we broke that down a little bit further into quarters because we found out that the contracts all started at different times. So for example, the HIV contract runs from October to October, while the STD contract runs on the calendar year from January to January. So, you know,
Never easy.
Yeah, it's never easy. So, you know, you can call the STD contract the 2012 contract, but the HIV one, you're talking about the 2011/2012 contract. So we broke this down into quarters so that we could really look at those, you know, up against each other. And when we didn't have vouchered costs available, because not all vouchered costs were broken down into categories, we looked at their most recent budget modification, which I feel should be pretty accurate, since the bureaucracy that we have will not allow you to move your money from one line to another line without a 15-page document in triplicate explaining why you want to move your money. And you can't spend money in a line that you didn't say what you were going to do. So my assumption is that any money that anybody spent was at least well documented, even if there wasn't a voucher cost for it. So what did we find? We found that on average, we're spending about $6 million on this program over the past few years, and that's about $1.5 million a year, or $360 per county. Our county contracts ranged anywhere from $256,000 to $537,000 a year. And overall, salary and fringe made up about 89% of the total contract cost. The contracts tended to support anywhere between 5 and 18 employees, and their efforts ranged from 5% to 100% effort, which really made, you know, figuring out who's doing what and at what percentage difficult, because the way that they were reported wasn't consistent between the contracts. We also looked at how much the counties were reporting to have contributed towards this program, and that ranged anywhere from $21,000 to almost $200,000, and was about 6% of the total contract cost on average. And I really stress the reported aspect here, because we know from the site interviews that most of the funds contributed by the county are not actually reported on their contracts. So the next couple of slides include a series of graphs with some of the analysis of the cost information that we collected. And this first graph shows the total value of the contracts by quarter. And these values are a combination of both the HIV grant and the STD grant. It doesn't include the that third high impact prevention grant that I mentioned. And it covers every quarter between 2010 and 2013. And what we see is that the values have been pretty stable, and maybe decreasing very slightly. And this was not adjusted for inflation. So as inflation has gone up, we haven't given anybody more money. And in fact, we may have given them a little bit less money. And then the next slide, how did we spend these contract funds? So we can see that the percentage of contract funds spent on salary is pretty consistent among the counties. It's right there around 60%. And together, salary and fringe make up a minimum of 80% for every county. But the biggest difference that we really see here is the percentage that they spend on fringe, which varies pretty significantly between between the 4 counties, and that's the color in dark blue there. The next graph models the total salary expenditures that we had between 2010 and 2013. And you can see that over the course of 1 year, the salary expenditures aren't even consistent within 1 year. And we noticed that numerous contracts where different employees are funded for different quarters of the contract. So we think that a lot of this has to do with staffing changes, unpaid leave. In some cases, counties ran out of money on their grant, so they didn't use grant money to pay their staff that month or in that quarter. And there were also times where they had money left over in a different budget line, so they moved it and reallocated it towards a worker who works full-time doing grant activities but isn't paid full-time on the grant. So what we see is that this is really a representative of one of these challenges of trying to do microcosting in practice. Nothing is really static. Nothing is as they planned it out to be when they submitted their budget at the beginning of the year. And I think that was one of the great things about doing the site visits, is that these are the kinds of things that we were able to learn about. And on the next slide, we've got fringe rates. And we broke this down by quarter. Basically, we saw that this has significant variation. It's all over the place. And in some cases, this was also a situation where they just ran out of money, so there was no fringe on a contract for a particular quarter. And I also wanted to mention that this is also dependent upon the previous graph, since fringe is a percentage of how much they spend on staff. But this doesn't exactly follow the same pattern that the staffing one did. So it's really, it's very messy, and we're really trying to figure out what in the world is going on with all of this. So, and then finally, we have the amount that the county reported as contributing to this program in red compared to the value of the total contract, which is in blue. And they indicated this in their contracts in a variety of ways. Some counties specifically mentioned that they were making a, quote, in-kind contribution to the program, while others mentioned that they had a certain fringe rate that was, they had 75% fringe, but there was a cap at 45, or they wanted to pay for travel, but they didn't have any more money, so they weren't going to put that in the grant. And some counties just didn't mention anything. They would leave sections blank. So that brings us to some of the limitations of this contract data. So I just mentioned that the counties are contributing funds to the program, but really we don't know how much. There's so many different variables about, what they could be contributing and they're not telling us about, and things that they probably don't even consider because they just think about them as sunk costs in terms of space and computers and things like that were already in the building. We also had some very inconsistent salary information, and part of this was due to the way that the contracts were set up. So in 2012, they had all of these interim contracts where they were in increments of 3 months or 5 months at a time. And when we looked at salaries from the first 3-month contract, the person, an individual would make $10,000 more or less on one side or the other of this, which something about that seems a little bit like creative accounting. So we're also trying to figure out what's going on there. The administrative rates that they would list in their contracts went anywhere from 0 to 10% and everything in between. And since there's a 10% cap on this, it just kind of seemed like a line in the contract that was a catch-all for any money that they couldn't budget elsewhere to make sure that they got the full amount of the grant. We had issues with fringe, particularly because one of the contracts was capped at, they had a 45% cap on fringe rates for quite a few years before they finally lifted it. We had a lot of counties that weren't allocating any dollars for travel when we know that travel is an essential aspect of providing partner services. You know, you have to go out there and you have to see these people. We also saw that some staff weren't fully funded between any of the contracts, but having met them in the field, we knew that they were doing the work of at least one, if not 1.5 FTEs. And finally, we have that issue where these contracts include funds for things other than partner services activities. And the big question that we came out with here was, how do we separate the partner services activities from all the other activities allowed under the grant? And how do we determine what percentage of staff effort is actually going towards partner services? Because one of the other issues that we saw was that some employees are funded on grants for other communicable diseases. So Brittany mentioned, meeting staff who are funded also on TB grants. And while their effort allocation may say like 50% TB, 50% HIV, after talking to them, we found out that that may not be the reality of the situation. So trying to find out, what those allocations actually are is kind of like where we've gotten to next. So what are our next steps? So, understanding all of these limitations that we didn't expect by pulling data out of the contract, and in addition, speaking with a lot of the other PBRNs who were doing DAC studies while we were at Keeneland, we came up with these two tools that we're working on developing right now. The first is going to be an employee effort survey to really try and determine the actual percentage of their time devoted to providing partner services. That'll help us break down what's partner services versus what's educational programs, and also those people who are funded on like STD and TB grants at the same time, how much effort are they actually putting towards partner services? And then the second one is going to be a management costing survey, which is going to help us collect the costs on those fringe, the overhead, the administrative, and the travel, the things that we really couldn't get consistent from the contracts. And we're hoping to get these out in the next month or so. And I just want to say a thank you to North Carolina for sharing their tool with me, because I'm going to use that, to try and base this off of in part. So thank you.
So this is Brittany again. Just in terms of lesson learned as we're going through this research process, first and foremost, designing a good time study takes a lot of work. I know we've heard a couple of DAX groups talking about trying to do a time study because, of course, we encounter these challenges with some of the cost data that we have. If you haven't started working on that yet, definitely start now and really get input from the practice partners, because it's been essential to getting buy-in and helping us really design a tool that makes, that we're pretty confident will have good quality data coming in that we can apply to model. With the contract review, with the site visits, with the development of the time study, we're really getting a good handle on what we don't know. We know what we don't know. Understanding the limitations of the data that we're working with, understanding how, in other sites, if they were to do similar models, some of the challenges that they might encounter has been really helpful in, either helping us design some new instruments to get at those areas that are still a little confusing, or to help us design good instruments and kind of build our evidence base of what's going on out in the field. And obviously, as Tori has shown, using contract data for cost estimation probably doesn't reflect the full cost of services. Whether the counties aren't reporting it, people are still getting paid, paychecks are still going out. Where that money is coming from is still somewhat of a mystery, and I think any attempt to use this type of data to cost will probably be an underestimate of that, mythical true cost, or the true cost of delivering public health services that so many of us are trying to determine. So for our research timeline, we've wrapped up that time study instrument in terms of developing it. We've done the interviews. We've collected some of this cost data. Right now, we're designing those employee management surveys. We're launching the time study very shortly, and then we're going to continue working with this contract data to identify any other challenges or limitations we might have with it. And obviously, the big upcoming activity is to work with our practice partners here on the cost-effectiveness model development. and really piece together all of this information that we have, the qualitative, the employee effort and case effort information we're going to get from the time study, and then the program cost information that we're getting from the contract review and the surveys. And then, piecing that together to really come up with something that will give us estimates of how much it costs to deliver these, what type of effort goes into it, and what might impact that. Of course, none of this would be possible without the New York State Department of Health staff letting us pick their brains and come into their health department programs and work with staff to do this kind of research. So a big shout out to the state staff who've helped and the local health departments who have invited us in and by and large are really excited about this project and on board with it, which is really great to hear. They're excited to see the findings and invested in this as much as we are. And obviously Erica Martin and Johnson Chen, who have been rigorous in making sure that we're designing these tools and implementing this research in a really robust way. So the Rockefeller Institute of Government, where Erica is, in the University of Albany School of Public Health. And obviously Robert Wood Johnson and the PBRN for always supporting this kind of research. So that's it for me, or for us, I should say. Does anyone have any questions?
Thank you so much, Brittany, for that wonderful presentation. I'm especially thankful for the advice that you gave on designing a good time study instrument. I think that's going to be obviously invaluable to all of the other networks that are doing these types of studies. So with that, I'd like to go ahead and open the floor up for questions. If you want to use the chat box, you can do that, or if you want to just go ahead and speak up, you're able to do that as well. Go ahead.
Yeah, this is CB from the PBRN Coordinating Center. Brittany, is the time study instrument, is that going to be paper-based or is that an electronic entry?
I would love for it to be electronic entry, and that was one of the things we were initially trying to do, but ultimately a lot of these health departments are still doing everything in paper, and there would really be no way for us to have an electronic entry tool that could be utilized by everybody equally. And by and large, the consensus was we had to go kind of Stone Age tech and just use a paper instrument so that it was something workers could take with them out in the field and carry with them in their case pouches. But ideally, this is something that we could shift into an electronic entry type tool if other health departments were trying to do this and had a little bit more resources at their disposal.
Okay, thank you.
Brittany, I have a question from Hector Rodriguez. He wants to know, are community-based organizations also involved in partnership activities? It seems as though partner notification can be facilitated through existing networks that can be accessed by CBOs.
That's a really good, yeah, it's a really good question. There are different models of partner services across the country. Some of them more heavily involve CBOs than others. New York State, really, their partner services program is pretty heavily focused on health department partner notification, particularly because of their access to surveillance data and laws limiting the sharing of that information with CBOs. At least in New York State, we have some pretty restrictive laws about that. But we are in the process, actually, of expanding and trying out new models of partner services that are really going to bring in healthcare organizations a lot more. So this research that we're doing now is kind of laying the groundwork for future research that we can kind of expand to CBOs. So we're not there yet, but we're hoping to get there soon and bring them into the fold as well.
Thank you for that. Any other questions? I have an Anna Hoover question. Do you have a theoretical framework that guides your research approach? For example, organization readiness for change, or maybe that's not the relevant policy theory. Maybe there's another one. So I guess the real question is, how do you think your work fits into the broader social scientific knowledge base?
Oh, that's a heady question. Okay. I have Erica Martin.
I thought it was an Anna question
as well. I know, I like how you blame that one on Anna. That is a really good question. I think the kind of overall goal of this research, at least, and I'm kind of more speaking for myself than the broader PBRN maybe, is there are a lot of shifts in public health and partner notification and health, public health services that are being delivered by the health department, and unique skills and tool sets that we have, like access to surveillance data, that make us uniquely capable of doing this type of notification or relinkage work that a lot of healthcare systems don't have access to. And part of this DAC study, and in my grand plan, if you will, is to try and show how valuable health departments are in being able to partner maybe with healthcare systems and relinking people to care and improving population and community health, and in using the unique tools like case investigation and surveillance data to build that up and to kind of serve as a key partner in making sure that healthcare is delivered effectively. But that's not necessarily a theoretical framework. I'll have to get back to you on that one.
Sounds good. It's homework. Also, I was wondering if you faced any IRB challenges in tracking costs for HIV and STD, or do you want to describe some of those?
We actually didn't have to go through IRB approval because this is actually all our own workforce, and it's workforce data and workforce research, which didn't need approval through the New York State Department of Health. If we were to do this, say with CBOs or expanded on a broader scope, we might encounter some of those issues. But for us, at least, the IRB process was pretty quick and painless. We sent it by them, and they said since this is workforce research, it doesn't need any unique considerations or approval.
Thank you, Brittany. Does anybody have any other questions?
I just want to make a comment about the study. I think one of the really fascinating or interesting slides that you guys showed was the slide where you showed how the breakdown of how the total contract funds were spent by county, and it's something that we're looking forward to when the other DAC studies also present the results. It's of course the challenge of being able to estimate accurately the cost of providing these services, but it's showing some consistency, especially how you show how anywhere from 60 to 80% of the cost of these services really come from personnel and staff or labor costs in general, and that's pretty consistent across the literature, even in other fields like in education and providing these different public services or governmental services. So that was a pretty I think interesting result that you guys presented this afternoon.
Yeah, and I think workforces are the most valuable resource we have, and how we use our workforce and all the skills that they have to maximize health impact. So I'm really excited to do the time study. So I think we'll be able to show ways in which we can improve and make their lives a little bit easier as workers, and free up their time to really do more actively community engaged notification and partner notification work.
Well, I'd like to extend a big thank you again to both Brittany and Tori for the wonderful presentation.
Thank you.
Thanks a lot, guys.
So moving right along to our other meeting agenda items, we're pleased to tell you that we're going to be resuming our monthly improved calls. This is again the multi-network practice and outcome variation examination study that the grants ended back in November. And at that point, most of the 6 networks that participated in the study had just finished their data collection. We've obviously now moved on to the analysis and interpretation phase. The center has created a draft state-level report, and of course, many of you have already done some data analysis on your own. So we're looking forward to sharing some information and also hearing from you about where we are and where you are and where we want to go and where you plan to go. For this next meeting, we're going to be joined by the Delivery and Cost Studies grantees. That's our DAX project, of course. And of course, many of you overlap. CBG, do you want to say anything about this?
Yeah, so the format for the next virtual meeting in May 23, we'll still have the usual time that we give to each of the 11 DAX grantees to give us, a 5-minute update on the progress or status of their research. And so that should take about, anywhere from 45 minutes of the meeting, 35 to 45 minutes. So please do prepare the usual short update, especially in terms of if you have any also results, preliminary results to present, that would be to share, that would be appreciated. That's all.
Excellent. Thank you, CB. So again, this meeting is Friday, May 23rd from 1 to 2:30 p.m. Eastern Time. And if you are an Improve or a DAX grantee, you should have already received an email invitation from me about this. Okay, so moving right along, I wanted to give you an update of our newest funding mechanism, the Dissemination and Implementation Research to Improve Value, or the Directive study. And this funding mechanism was developed to fund projects that compare the effectiveness and cost of dissemination and implementation processes within public health systems, while also examining the number and while also expanding the number and variety of practice settings engaged in applied research through the PBRNs. We really want to congratulate the networks that applied for these awards. This was a complicated process requiring consortia of at least 2 networks and the involvement of at least 100 practice settings across the participating networks. Certainly not a small feat to organize these partnerships, and furthermore, these studies were expected to build upon the Improve and DAX programs using improved measures and DAX cost methodologies. So we realized that there were a lot of moving parts to this proposal. We raised the bar, and you guys really rose to the challenge. I'm pleased to tell you that we had 7 applications constituting 17 PBRN networks and 1 non-PBRN state. We will be able to fund up to 4 of these projects. We're currently in the review phase of this proposal. The applications have been sent out for external review, and we hope to have final recommendations out to RWJ sometime in June with grant start dates of mid-August. And of course, these are two-year, 24-month projects, $350,000. Next, the Quick Strike projects. Thank you for your patience regarding these Quick Strike proposals. We are pleased to tell you that we have awarded 2 of these awards, one to the Ohio PBRN, who will be investigating the process, structure, and outcome of community health improvement planning and community health assessment and community health needs assessment efforts in Ohio local health departments and hospitals. The second Quick Strike Award goes to the Washington PBRN, who will examine the impact of decreases in public health investment and staffing for violence and injury prevention activities in the 9 local health department members of the Washington PBRN. These are both timely studies that address important gaps in emerging issues in public health. We are in the process of reviewing the 3rd and quarter proposals, and we will have decisions for those other 2 awards by the end of May. Next, I'm going to turn it over again to CB to discuss the Foundational Capabilities Cost Estimation Pilot Study with the Kentucky PBRN.
Thanks, Lizette. As some of you have known, Dr. Glenn Mays has been leading a national work group, expert work group on looking into estimating the costs of the foundational capabilities and foundational areas of local health departments. And so he wanted to share the good news that we are going to start a pilot study that's gotten strong endorsement and support from the Kentucky Public Health Research Network, or KFRN, and Kentucky Health Departments Association. And we're hoping to start a pilot study that will develop an instrument that will hopefully we can apply nationwide. So this is something that we're looking forward to carrying out this summer. That's all.
Thank you, CB. Any questions on those items so far? Okay, so moving on to dissemination opportunities. As always, we encourage you to submit your findings to Frontiers, our open access, quick turnaround online journal. And as I know you've seen this announcement for a while in past meetings, newsletters, emails, social media, the deadline for submissions to our AJPH PHSSR special issue is midnight tonight. So you have plenty of time after we finish this call to make those last minute touches and get your manuscript in before midnight. Okay, so next slide. I wanted to remind you that the survey for the annual PBRN grantee and Keeneland Conference meeting closes next Friday, May 23rd. So if you have not yet completed the survey, please do so as quickly as possible. This is your opportunity to let us know what you liked and what you didn't like about the grantee meeting and Keeneland Conference this year. We truly value your feedback, and we use your comments to improve our processes and to learn how to best serve you. If you did not receive a request to complete the surveys, please send me an email after the meeting, and we can address that. Next is the PBRN social network analysis. I know we've been telling you for the past few months that we're getting ready to field this again. You know, we have had a bit of workload issues with various projects, but really soon we're going to be ready to send this request out to you. So thank you for those who have sent your network rosters. We really appreciate it. And we'll be contacting any networks that have not sent in their rosters pretty soon. I also wanted to let you know about a joint Improve Index panel at APHA. Colorado, Minnesota, Florida, and the Connecticut networks will be presenting findings on the Improve Index research. And we're really very excited about this opportunity to share this great work with a much wider audience. So thank you for that. The next item is the Academy Health Fireside Chats on public health funding. And this is just a question for me, really, because the last of these 3 chats occurred yesterday, and I do hope that some of you were able to attend. These virtual meetings were, again, hosted by Academy Health and focused on the congressional appropriations process and the budget process and what all this means to PHSSR research. So we would really love to hear your feedback on any of these calls if you guys attended. And lastly, we ask you to please let us know if you will be presenting at either Academy Health or NACCHO. Please send us the title and date, time of your presentations, and you can send it to the Public Health PBRN at UKY.edu account. We really need to have a list of all of those presentations from the PBRN, so thank you in advance for that. Any questions before I go on? Moving on to funding opportunities. I think someone's phone might be on. There we go. Okay. Currently, we have opened the Public Health Services and Systems Research 2014 Call for Proposals. This solicitation will fund up to 9 studies of up to $350,000 to expand evidence for administrative and policy mechanisms that improve quality, efficiency, and value in public health delivery. This mechanism closes July 23rd, so I encourage you to read more about this. The CFP is on our website, PHSSR, under funding mechanisms, so you'll be able to read the entire CFP from there. Next, we have the RWJ PPS PhD. This is the predoctoral and postdoctoral scholars in public health delivery. And these are $25,000 12-month research awards intended to help develop the next generation of researchers in PHSSR by providing funding to support rigorous studies on the organization, financing, and delivery of public health services. Now, these awards are intended for predoctoral or early career postdoctoral researchers. What we need is a letter of intent from the scholar and their mentor, and that's due by May 28th. We will then review those, invite full proposals, which will then be due by July 15th. Again, you can find all of the details on our website under funding opportunities. And this is a good month. There are lots of awards for scholars. The next award that you see here is the William T. Grant Scholars Program, and this supports promising early career researchers from diverse disciplines who have demonstrated success in conducting high-quality research and are seeking to further develop and broaden their expertise. Candidates are nominated by a supporting institution and must submit 5-year research plans that demonstrate creativity, intellectual rigor, and a commitment to continued professional development. Every year, 4 to 6 William T. Grant Scholars are selected, and each receives $350,000 distributed over a 5-year period. So this is quite a prestigious award, and you can find the link on the link with more information on the agenda that I sent you with the original invite to this meeting. You can click directly from that. And next is the 2014-2015 Alvin R. Tarloff and Johnny Ware Jr. Doctoral Dissertation and Postdoctoral Awards in Patient-Reported Outcomes. This award is through the Health Assessment Laboratory, and the purpose of these awards are to encourage doctoral dissertations and postdoctoral research using patient-reported outcomes. Again, they offer 3 awards, $25,000 for the next academic year. So a lot of opportunities out there for young researchers. Again, I encourage you to take advantage of those. Any questions? Okay. Before we close, I would like to remind everyone of the schedule for the monthly Research in Progress presentations for the rest of the year. As you can see on here, California will be next, presenting June 19th. And if you have any conflicts, please remember to try to switch it with another network. If you cannot find another network to switch with, then you may call me and I'll be happy to assist you with rearranging that schedule. So with that, if there are no more questions, we can end quite a bit early. Any questions? All right, excellent. Well, thank you so much for your attention, and thank you again to the New York PBRN for today's presentation, and we'll see you next month.
Bye, Lizette.
Hi, Nancy. Thank
Bye.
you.
Thanks.